Hey guys, Anthony Avila, Doctor of Physical Therapy, owner of Avila Physical Therapy, host of your Coastal Bend Spotlight series. Today we're spotlighting a surgeon who represents the highest level in sports medicine. Dr. Kyle Wilson is a board certified orthopedic surgeon, fellowship trained in sports medicine at Mississippi Sports Medicine and Orthopedic Center. He specializes in arthroscopic shoulder, elbow, and knee surgery, ultrasound guided injections, and total shoulder replacements, helping athletes and active adults stay strong and pain-free. Beyond the operating room, he's received multiple awards for teaching and research, served on international medical missions in Guatemala and Kenya, and continues to advance orthopedic care through innovation and compassion. Let's dive into his story and welcome Dr. Kyle Wilson.
I appreciate that intro, Anthony. Great.
Thank you so much for joining us today. We'd absolutely love to hear more about your story. How did you develop a passion for helping people stay active? Is athletics a part of your story? And why did you choose to become an orthopedic surgeon?
That was definitely the introduction for me to orthopedics. Growing up playing sports, playing football, then playing in college and getting introduced to our team at orthopedic surgeon, where I played in college at Texas Lutheran. And that was really my first introduction to sports medicine, not really growing up around it, and just really loved it. And it really took off from there, got involved in research, got involved at a surgery center, and the rest is history.
So would you say anything ties from those football days as far as, being able to get to that level of competition? There's a lot of work ethic, team building, that kind of thing. Does any of that contribute to what you do today on a day-to-day basis?
It certainly does. I would say time management is what I get this question a lot. Time management, I think, is the probably my default answer. And it's a good answer. You go through years and years of hours long practices in a day and have to balance that with, your studies, et cetera. You transition away from playing sports and playing at a high level, and you feel like you have so much time on your hands, and you can reallocate that intensity, that commitment, and you feel like you have a ton of time. I remember getting out of playing football and just feeling like so much time on my hands. So, yeah, I would say time management, perseverance, yeah.
Time management, definitely important, not only in the college days, but as you mentioned, as you transition into a work environment. And with that, I know a lot of patients come into your office with shoulder or knee injuries, and there can be a drastic change to someone's ability to carry out their own day-to-day routines, whether it's an everyday parent trying to keep up with their job or family routines, or an athlete who all of a sudden, has to step away from everything they've worked so hard to accomplish. Now these clients are coming to you in your office and seeking your help. So is there a deeper meaning for you beyond the medical side of things as to being able to help these patients?
Oh, yeah. And I think that's one of the things I enjoy most about orthopedic surgery is getting people back to that baseline level. You can get people back to doing what they love to do. The goal for me is not to necessarily manage a condition per se. It's to treat it and treat it effectively and get the patients back at a very high level doing whatever their desired physical activities were. So that is just profoundly satisfying to me. Yeah.
Yeah, for sure. Those patients are definitely on a goal to get back to what their, baseline is, what they've been used to doing. And especially someone who has a shoulder injury to their dominant arm, that's a big, big setback. And so is there anything success-wise or patient-wise that you see commonly when someone's coming into your office with a particularly dominant shoulder that they're no longer able to use, that you guide them towards as far as what that recovery is going to look like?
I think a sort of general thing that I sort of anecdotally say that correlates to a pretty high level of success is the pretty thorough understanding of not only the surgery, but the level of commitment required, postoperatively with the rehabilitation. And I always emphasize that that's pretty much just as important as the surgery, And so if there's that mindset that the surgery is not just a sort of quick fix, that there's a steady commitment afterwards, and they have that sort of a clear understanding of how important that is, that I'm pretty confident that that patient is going to do quite well.
Yeah, understanding what you're about to get into is such an important thing. And the education around those healthcare decisions you're about to make is such an important thing. In your view, what defines exceptional care beyond outcomes? Are there certain standards or values that define what you view as exceptional care in your clinic and beyond?
Yeah, I would say first and foremost, availability, being able to accommodate the patient's, be able to, be accommodating to the patient's time. I think ability, staying up to date with the latest, modalities, trends, the science, and knowing how to understand the science, knowing about how to parse through what is good science, what is the latest, TikTok fad video. Is there any, true science behind that? Or is that just, a creative marketing ploy? There's just a tremendous amount of nuance from that standpoint. So yeah, definitely that availability, ability, the three A's, and then the affability, being able to get along with the patient and get along in a useful way. You don't need to be necessarily friends per se, but you can be able to encourage them through, because there's going to be some ups and downs, and you'll be able to sort of encourage them and talk through sort of the tougher scenarios. It's pretty unlikely that it's pretty rare for, especially over a long time horizon, for instance, like an ACL, see them over a long period of time, up to a year after the surgery. There's going to be periods where they're just accelerating and doing exceptionally well, and then periods where they may tend to plateau. So being able to sort of talk them through those sort of lulls post-operatively, especially for patients that have very high expectations, as they should, to get back out doing what they want to do.
So you touched on it a little bit here, but I'd like to dive a little bit deeper into what kind of conditions do you most frequently see? We know your focus is mostly around the knee, shoulder, and elbow, but are there certain cases you often see more than others within those regions?
I see a lot of shoulder and knee. I think by default, those are the more common injuries. I would say shoulders. I see a ton of rotator cuff injuries. I see a lot of labral injuries, instability type injuries. For knees, I see a lot of your ACLs, meniscus tears. And that's my sort of younger athletic population. And then for the patients that are a little older, I'll more often see sort of the arthritis conditions, in addition to rotator cuff injuries, but also a lot of arthritis conditions. And so I'll see a lot of shoulder arthritis specifically in our group.
Yeah, so within those two populations that you mentioned, the younger athletic age as well as the older age group, is there certain patients that tend to thrive with your care? Is it more of a proactive patient, or an active patient or athletic patient? Is there certain characteristics or routines that you see from patients coming in that tend to do well with your care?
Oh, there's no doubt. It's patients that are bought in, that have an interest in their care. I get a lot of the sort of hesitation from patients when they say, "Well, I found this on Google or ChatGPT," and I actually love that. I encourage that. I think that there's a tremendous amount of information out there, and no single individual knows all the information. So I love that sort of interaction where it's sort of a team approach, where it's not just, me, the surgeon, telling somebody everything. They're bringing what they know to the table, their story, what the sort of research they've done. And that also tells me the level of commitment they're going to have. And so I think with a lot of these injuries, and again, with the type of surgeries I do, like that's just such a necessity to have that sort of buy-in, that interest in the injury, that commitment to the long-term rehab. Yeah, that just, like I mentioned earlier, there's a very strong correlation to a positive outcome.
Yeah, and so you mentioned all the resources out there as far as, AI and the internet and TikTok and videos and all of those things within that spectrum. Is there anything commonly spoken about that is fairly misunderstood? Anything about your role or your specialty or the surgeries in itself that you'd like to address and further clarify?
Yeah, I think I have a lot of conversations about stem cell therapy. There's a tremendous amount of interest, and rightly so. Patients are in pain; they want a treatment, and I would tell them to, and I often tell them to be very cautious about, spending $8,000 to $15,000 of their cash to get these stem cell injections. I always say, if these worked, I would do them. To be very blunt, it's a very easy thing to do. I just, very ethically obliged to recommend things that have a high degree or high probability of working, with proper evidence, level 1 to 3 evidence for the most part. So, have that conversation quite a bit. And I love having that conversation. I'm very intrigued by the science. So that's definitely one. I'd say be very careful before you go out and do some of these more sort of esoteric treatments and, subject yourself to what may be some pretty strange complications other than just losing a tremendous amount of cash.
Yeah. Yeah.
Yeah, I would say that for sure. And don't dismiss doing your own research, but be mindful of where you're doing your research. Um, I think a lot of these LLM models now, whether it be Perplexity, whether it be ChatGPT, Gemini, whatever, they're pretty good now. They're pretty good now. So I would sort of interact with those and even come with questions. Because there have been times when I don't know, and I explore that with the patient, and I love doing that. But I would be very careful about these quick sort of 10 to 30-second videos people see on like TikTok or whatever social media app they're using. I would strongly advise against that.
Yeah. And so we see similar things in the clinic as far as, people coming in with very similar diagnoses, but they all have their own individual story, own individual perspective as far as the comorbidities they're dealing with, the resources they have, the time they have to invest in what they're going through, that kind of thing. So with those individuals, as they're sifting through all their resources online, how do you guide patients to sift through the real evidence versus something that is just kind of clickbait?
Right. No, and that's $1 million question is, and it's partly, your job, my job as professionals to, to address those questions because I get them so often, but definitely consideration of sources. Have that discussion with your health provider, health professional, because it's their responsibility to stay up to date with most recent literature, the most recent high level research. I
Yep.
think the other thing to be cautious of too, since you're asking me about what to be cautious of, whatnot, is be careful of a lot of the reviews. Use it as an additional data point. Google reviews, Yelp, whatever. Just be mindful. It's so difficult to know as a consumer, as a patient, to know what to trust per se when you're making these health decisions. You just don't know. You just don't know. I get that. I understand that. But, the more different data points you can have, say, look at a Google review, do your own research beforehand, the more variables you can consider, coming into that appointment, more questions you can have beforehand. That'd probably be another thing that I see quite a bit, and that correlates to a pretty good outcome is when patients come with a list of questions. I always encourage that. I encourage that from family members, especially, as sort of often rushed and complex as these interactions can be.
Yeah. So that's got to be such a positive thing for the community to hear from that perspective that, professionals out there are seeking them to go ahead and do your research, bring that in. Let's go over what you found and let's create an individualized plan for you. And so that we can treat what's going on with your specific story and background. And so when they're researching, maybe they come across something that sends them the wrong way. And their problem now becomes, for instance, like with the shoulder, you can develop adhesive capsulitis or frozen shoulder or those kind of things. And so if someone's hesitant or unsure about reaching out, what would you want them to know?
Well, I wouldn't hesitate. I guess that's easy for me to say, but, because there's a lot of complexity to seeking care. I would not hesitate. At the same time, if you go to these encounters and you seem uncomfortable, you seem rushed, it's very reasonable to, talk to another professional, get a second opinion. Anybody that discourages a second opinion, I would not let them operate on me or provide my care,
Right.
In terms of these specific diagnoses and the implications of waiting too long. I mean, that's all across the board. Something like
Right.
adhesive capsulitis, oddly enough, it stings for quite a while, but if you, give it long enough, in some cases, even 1.5 to 2 years, it often will,
Right.
get better on its own, but that's a big part of your life. There's things that can be done to expedite the process. But in other injuries, though, fractures, there's some ligamentous injuries. Um, yeah, there are definitely some negative implications and negative side effects to, waiting too long.
Yeah, so for sure, do your research, but let's let that expertise also be another point of interest that you collaborate with, and don't use, maybe the internet as a substitute for more than what it's meant to be. And so I believe that's the message that is being mentioned here.
Data point, use the internet, take it into consideration, and find a health provider that you trust. Yeah,
Yeah. I often get the question around imaging within the clinic. And so, x-rays, MRIs with regard to shoulder or knee injuries, how important is it to understand the value of a thorough examination from a specialist and not just purely rely on imaging and imaging studies?
profoundly important. These imaging studies are so useful, they're so critical, but there's a lot of incidental findings nowadays. For instance, as MRIs have gotten so good, that's a wonderful thing, but they can pick up a tremendous amount of things that aren't necessarily the true sort of pathologic lesion per se. A vast majority of shoulder MRI, especially if you get, say, over 40 years old, will find a lot of stuff. To what extent is each one of those findings really clinically useful? That's again part of what you do, what I do, help parse through that and figure out what the true pathologic injury is that needs to be addressed. And so, I mean, it's everything. No, I think reliance solely on just an imaging study is not a good idea.
Yeah, so sometimes we can see those distractors, that are picked up on imaging and maybe take you down a rabbit hole that you didn't need to go down if you had just utilized that within the realm of, an evaluation with a specialist, and putting it all together in an examination, not just one specific part being the imaging or the imaging study.
For instance, in shoulders with slap tears, we see just y- to an extent where you could almost get an MRI on almost everybody 50 years or older, and you'd probably be able to see a slap tear in every single one of them. Now, it doesn't necessarily mean you need to go in and fix 98% of those or address 98% of those with any specific surgery. It's just, yeah, there's a science to knowing what truly needs to be addressed. There's an art and a science to knowing what truly needs to be addressed.
That's definitely helpful to keep in mind and understand, especially as you mentioned, research and technology continue to advance with imaging. You're here for a reason, we're here for a reason. And so I'd like to also mention, with bigger surgeries, what are some things that patients should consider when they're going for one of those? So, say maybe like a total shoulder replacement, an ACL surgery, a bigger rotator cuff surgery. What are some common questions or things that patients should be aware of, and keep in mind? What should they be prepared about going for one of those surgeries?
Preparation, I'll hit that first. I think it's a good question. Preparation is critical. Being mindful of one's general health is super important. Are there any heart conditions, stomach conditions, lung conditions, etc., that would make an anesthesiologist quite uncomfortable, administering anesthesia to even do the surgery. So how's your general health? So being maybe mindful of having an up-to-date appointment with your primary care provider to make sure that that's addressed first. Because if you come in and see a specialist in, surgery is a moot point if you have a really bad heart condition and you can't get anesthesia anyways. So being mindful of one's general health, we see a lot in this area. Diabetes, how well is your diabetes controlled? Make sure you have an up-to-date hemoglobin A1C, shooting to get that, I don't want to give a specific number. Your primary care provider will give you more specific numbers, but there are high numbers that would stop one from having surgery and indicate that that's sort of the main priority of getting that blood sugar under control. Those are, I would say probably very good things to think about before coming in and seeking a surgery. Um, things that you can control: cigarette exposure, nicotine exposure, minimizing that for sure, especially if you're thinking about surgery. And that's nicotine from any source, whether it's cigarettes, patches, gum, vaping, it doesn't matter. It's the nicotine exposure specifically. Um, those are important. Alcohol, other drugs of various sorts, be careful to minimize exposure to a lot of that stuff if you're thinking about having surgery.
Yeah, so with ACL surgeries, rotator cuff surgeries, I wanted to touch on those as well in a little bit more depth. Do you have to have an ACL repaired once it's torn, or what degree does a rotator cuff need to be repaired once it's torn? Where are we at with that on research, and can you offer a little bit more insight on that?
The general answer is no, having an ACL tear or having a rotator cuff tear does not necessarily mean you need surgery. Absolutely not. And in fact, a lot of people, and I have this conversation a lot of people are quite functional with an ACL deficient knee, a knee that doesn't have an intact ACL. Yeah, there's more nuance to that. That typically involves more inline activity. You're doing okay, but once you start incorporating a lot of repetitive pivoting side to side type activity, your knee can start to feel quite unreliable. You realize that you're sort of consciously thinking about knee position, et cetera. So that can get quite old for an active individual, but can be, and you probably see this from a lot of the referrals I send, can be worked through with a lot of, very well done ACL deficient knee physical therapy programs. And very much the same could be said about rotator cuff injuries as well. Now, with ACL surgeries, in terms of where the research is, there's two distinctions that can be made with doing an ACL surgery. You can either go in and actually do a primary repair of the ACL, or you can reconstruct it and build a new ACL. There is some unpredictability, quite a bit of unpredictability with going in and repairing an ACL. It's got to be a specific type of ACL tear, a top-sided proximal ACL tear, right off of the femur, an avulsion type tear. But that can be very difficult to trust that ACL tissue, even if you get it to scar back down to bone, it's still theoretically sort of stretched out, and it's questionable whether or not it will function as a truly effective ACL and be properly taught, so to speak. Now, there are some newer implants like the Bear implant that's been introduced that I think shows some promise, but still a lot of questions remain. And so that's an important thing for me, especially in a younger patient, athletic patient. I'm in a position, especially as a community level orthopedic surgeon, where I have to, if I proceed with a surgery, I can't necessarily do an experimental surgery per se. So the ACL reconstruction, where you go in and actually build a new ACL, has a much higher degree of predictability and success, both in terms of long-term outcomes, but also in terms of the rehab process afterwards. It's a very consistent program afterwards. And so, there's different things that we can use to reconstruct the ACL. I mean, this conversation, quite frankly, can last for a few hours, but I'll try to hit the high points. I'm a big proponent of graft from the patient's autograft. You can use patella tendon, hamstrings, quad. I'm a big proponent of quad, as you probably figured out, quadriceps tendon, ACLs.
Is there a reasoning behind the quad leniency as far as the type of graft?
Mm-hmm. Yeah, and so relative to the patella tendon, there's less morbidity in terms of long-term anterior knee pain. A lot of these patella tendon grafts, you take a central third typically at least of the patella tendon, so it has a high rate of pretty bothersome front of the knee pain, especially with kneeling, things like that over the long term. Now that's something, if you go to like a national meeting, there's intense debate on. Some people say gold standard this, gold standard that. So I think that's why it's important to follow patients over the long term, train your outcomes, and if you start having a very high rate of re-injury, that would make us sort of reconsider using another graft. You're never going to get away from re-injury per se. That's going to happen. I think I recently revised a patella tendon ACL and use quad as the graft. So the re-injuries will happen. It's just part of it, just like a native ACL will tear. But yeah, and so the hamstrings is a good graft as well. All these you'll tend to, I mean, at the end of the day, they're all pretty dang good grafts. The hamstrings tendon, especially in females, the females already have a relatively sort of weak posterior compartment relative, to the front of the knee, the quad. So I don't like to make it weaker by taking the hamstrings. And so I've trended away from the hamstrings unless it's like in a revision setting or another redo type setting. But most importantly, it's using graft from the patient that the body recognizes autograft. I still use allograft in plenty of cases. It does quite well. And in specific indications, you get into somebody that's a little bit older, the 35, 40, 45 crowd that's still quite active. It's hard to justify the additional morbidity of taking graft from the patient, as opposed to just doing sort of a well done, efficient allograft ACL. There's definitely still room for that. That's still a good surgery. Less urgency to doing the ACL earlier, in my opinion, based on literature, relative to like an acute traumatic rotator cuff injury, particularly an individual that was, had zero problems with the shoulder prior to the injury. Now, if it's a rotator cuff tear that's been in there for a long time, there's absolutely no urgency there. A lot of people can live with those, do quite well with physical therapy, but a partial thickness rotator cuff tear, a lot of those can do quite well with therapy and rehab. And I'll often emphasize prehab as well on a lot of these, both ACL and shoulders. Specifically getting baseline range of motion back prior to surgery, both in shoulders and knees and ACLs. Now back to the knees, there are some more urgent things that if you have an ACL injury, if there's concurrent injuries with it, like a meniscus tear per se,
Right.
or maybe like an end of the MCL, a distal MCL tear, or any of these ligamentous injuries that can be repaired per se, like a posterolateral corner injury, there is some acuity to that. So yeah, I mean, there's a very long-winded answer to your simple question that could take a
No,
while. There's a lot of
you're
variables to
good.
take into consideration.
What a great amount of information given there. And that goes to show you how much background you have to make some of these decisions, and how hard it would be to kind of come through a lot of this research on your own, starting with no baseline. And so, yeah,
I would heavily recommend just establishing a relationship with, you or an orthopedic surgeon. Again, if you feel rushed, take a step back. Quite frankly, none of these are life or death per se. And so, take a step back and maybe talk to somebody else, get a second opinion. But I think it would be highly advisable to at least establish a relationship with somebody like myself or another surgeon who does these operations and help you sort of parse through. And I would emphasize somebody specifically who does the operations, that can help you sort of parse through these decisions, because they're quite complex decisions. It's very patient specific. It's not the same for everybody.
for sure. And so we talked about, ACL or rotator cuff, specifically rotator cuff tears. And, you don't always have to have the surgery for those. And then on the other end of the spectrum, for maybe the older population, we're now seeing more total shoulder replacements. And so at what point does that come into the conversation? What kind of things are we looking for from a patient perspective before that becomes a real conversation for them to have?
Chronicity is important, meaning how long has it been there? If it's been there for, quite a long time, 6 months, 9 months, a couple years, it's a very, very large tear on the MRI with significant retraction. It's very far away from where it should be. What the muscle belly looks like on the MRI and the degree of atrophy is there. So those are things we look at and we take into consideration, whether or not a rotator cuff can even be fixed successfully. And that's called an arthroscopic, a rotator cuff repair. Most often done arthroscopic nowadays. Now, when we've deemed that sort of irreparable or not fixable, that's when we start to consider doing a shoulder replacement. And there's shoulder replacement that is specific to a rotator cuff tear, a rotator cuff deficient shoulder, is called a reverse total shoulder replacement. And that was designed specifically for these shoulders that don't have a reliable rotator cuff. So reverse the joint, they flip the joint, and they make the deltoid become effectively the dominant muscle in the shoulder to bypass the entire necessity of the rotator cuff. Now, it's still nice to have as much of the sort of rotator cuff intact as possible, as that can help with additional, long-term function per se, especially once you get to the bottom of, say, the more specific muscles like infraspinatus and teres minor. But yeah, that's the reverse total shoulder. And that's actually a very good operation in my hands and my practice. I do quite a bit of that surgery, but that's a surgery of last resort. That's not for a rotator cuff injury. That's not a surgery that's done as a first step. No, that's a last resort. With that being said, again, once you get to that point, it tends to have very predictable, good outcomes. But that's different from like a reverse total shoulder that's done for like a really bad fracture of the upper arm bone, like a proximal humerus fracture. That's a difference.
Okay. Yeah. So as far as the total shoulder or the reverse total shoulder, what kind of recovery should someone expect from that? Is that, something that happens quickly, or are they expected to gain most of their function, all of their function, or what are your expectations when you have a patient go through that procedure?
Yeah, generally pre-op motion has a high correlation with post-op motion. Um, s- there's a few caveats. If it's a massive rotator cuff tear and they have something called pseudoparalysis or pseudoparesis, they can often gain quite a bit of motion. Are they going to have the strength they had before? No, absolutely not. So the reasons necessarily to do them, first and foremost, is pain. And pain and function are the two things I take into consideration. So pain, first and foremost, is just pain that's unrelenting, that's not responding to any conservative management. That's when you start to. That's the first reason to consider doing something else. Pain management strategies aren't working, et cetera. And then function, yeah, function is a secondary consideration. Still important, but some of my practice is a secondary consideration. I do often, vast majority of the time, see improvement in function, but that can often take, some time, rehab, et cetera. Typically, the pain relief is often something that improves first.
Awesome to hear. We've talked about so much. Is there anything else on your mind that you want to touch on today as far as, what you do in your practice?
Yeah, I think, for me, physical therapy is important. So, when you have these discussions with, say, somebody that's going to do surgery on you, you get a feel for who they trust and locally with their physical therapy. You and I, we've had plenty of these conversations. It's a critical part to the recovery. I would be hesitant to have the surgery with a surgeon with one of these operations if there's not a sort of good relationship with some of the local physical therapists. And that's a pretty common thing now. So that's pretty reassuring. And so I would say that that's something I want to emphasize in addition to everything else we talked about today.
Awesome to hear. We appreciate that so much. And so, yeah, make sure that, going into these surgeries, you know what your plan looks like. That way we can help you get the most desired outcome to the best of our ability. And so it's great to hear we've been through this process several times, and we greatly appreciate the relationship with you guys and all the resources that are provided by you guys. So thank you.
Yes, sir.
Again, thank you so much, Dr. Wilson, for your expertise and willingness to contribute to our Spotlight series. Give back is a core value with Avila Physical Therapy, and there's no doubt that goal was accomplished here today. For everyone following along, stay tuned to find out who will make the next appearance on the Coastal Bend Spotlight series.